Hi, everyone. It's my pleasure to introduce myself for this talk on post-remission strategies in AML. Again, very happy to be here virtually. Would have been better in person, but hopefully next year. So I'm hoping that this topic actually is a bit of a controversial one and will generate some further discussion in a debate, which I'm also participating in shortly. But moving to the discussion at hand, these are my disclosures, which are also available on the website. And let's talk about what are we really doing in AML treatment. So there is a treatment paradigm that has been in play for the last 50 years or so. You do something to get the patients in remission. Now I'm going to stop here for a second because it used to be that actually intensive chemotherapy really was the only way to have a meaningful chance of getting patients into remission. The non-intensive options were dramatically lower in their remission rates, most generally applied to older patients and to those with very poor performance status. But more recently, even regimens that are termed non-intensive are souped up enough that lots of patients are getting into remission, and we'll talk about that. So you're getting patients into remission using either an intensive or non-intensive strategy. And then what do? After that, typically there's some type of consolidation, either ongoing chemotherapy, sometimes an autologous stem cell transplant, although that's less common in the United States. And most commonly, when we are trying to cure the disease, we try to get patients into allogeneic stem cell transplant. And then there is the question mark in front of maintenance. So maintenance therapy is standard of care in acute lymphoblastic leukemia and has resulted in dramatically improved survival rates in that disease as maintenance regimens were incorporated to the treatment paradigm. Maintenance has historically referred to something different from what you did before to get the patients into remission, a lower intensity ongoing therapy of unspecified duration. And in AML, we always wanted to do something for maintenance, except the problem was that nothing was actually resulting in improved overall survival. Now we have a change to that story. And what I will talk about is what do you want to do in the post-remission setting at any place along this treatment paradigm? Right after somebody gets into remission? Right after consolidation? Right after stem cell transplant? There are multiple potential opportunities for maintenance. So why are we even talking about any post-remission therapy at all? Clinicians have always known that when you look under the microscope and you see morphologic remission, it doesn't tell the whole story. The patient, unfortunately, might look well, feel well, have normal blood counts, and the marrow might look okay under the microscope. But clearly, our current strategies are not getting rid of residual disease. There are cells that don't look like all the others, which are failing detection under the microscope, and those cells ultimately will result in a relapse. So the idea is you want to be doing something even when the patient is in remission to try to control that residual disease population. Now, there are a whole bunch of different ways to measure the leftovers. Historically, looking under the microscope is what was done, and that's just not good enough. You can actually, even when you're very, very good at looking under the microscope, one is just simply not detecting the residual disease that is there. And using things like FISH, and then even more sensitively PCR, and then ultimately we will probably be using next generation sequencing technologies, you can have logs of increased detection of what those leftovers are. So measurable residual disease is actually likely to be found. The more sensitive the testing is, the more likely you're going to find something. And this is part of the discussion actually of MRD in AML, that what type of detection level is actually going to correlate with meaningful changes in outcome. Well, just recently, actually, a hot minute ago, there was a publication in JAMA Oncology, which is an impressive meta-analysis looking at all of the factors driving how measurable residual disease, or MRD, is associated with outcomes in AML. And we know it's prognostic. You can see here very clearly that both overall survival and disease-free survival are better if you're MRD negative than if you're MRD positive. And all of the factors on the other side of the graph, whether you're looking at different AML subtypes, different ages, pediatric, any which way you cut it, and importantly, whatever the modality of assessment was used for MRD, if you've got it, it is associated with worse outcomes. However, there are about 1 million more slides to describe what the details are of that discussion. Because just because something is prognostic, first of all, it doesn't mean you know what to do about it. And secondly, it doesn't necessarily mean that there should be a change in the therapeutic paradigm that I discussed earlier. And this is what we're going to talk about for the rest of this treatment-based talk. I think it's very worth looking, though, at this recently published meta-analysis, because certainly the statement that MRD is prognostic in AML is an important one, because it at least asks the clinicians, what could we be doing next for these patients if we are able to detect MRD? And importantly, you want to be asking your pathologist, what are we doing to detect MRD? Are we looking at flow? Are we looking at PCR? If the patient has a PCRable lesion, something like a core binding factor AML or NPM1, it's opening an avenue, a very, very important discussion that's going to be with us for the next decade for sure. So if you look at the prognostic stratification systems, and there are quite a few, but the ELN one is the one that we most popularly use. These kind of divide AML into favorable, intermediate, and adverse. They are based on cytogenetics and molecular abnormalities. And the idea is that if you're in the favorable group, typically there hasn't been a long-term post-remission strategy beyond induction chemotherapy followed by chemotherapy-based consolidation. Because the other stuff, whether it's transplant plus minus maintenance, hasn't been shown to improve overall survival typically for those patients in first remission. However, the bulk of AML, of course, falls into the intermediate and adverse risk groups. And there, the idea is that you really want to be considering something after they get into remission and something other than consolidation chemotherapy, because outcomes at 5 years are poor. They are especially low in older patients. And the question is, what can you do to hang on to that remission? We have an increasing proportion of patients in the intermediate and even in the adverse risk category who get into remission, but they don't stay in remission. So what can we actually do to keep them there? So stem cell transplant has been our go-to therapy. It's very commonly stated to patients that that is our only known curative modality, which is probably still true. And certainly if you look here at intermediate risk, which is what's in the figure, and you look ages 40 to 60, it has been the case that allogeneic stem cell transplantation just looked better than other stuff that we had, whether it was autologous transplant or chemotherapy. And that has been a go-to modality. There are exceptions to the rule, but mostly for younger patients, the survival benefit conferred by transplant made it worthwhile. Now, we wanted to get more people onto our only potentially curative therapy, right? So if allotransplant is the only way that we can cure somebody, we wanted to get more older patients to allotransplant because, as I said earlier, our historical use of what was called lower intensity therapies, which is typically a single agent hypomethylating agent or low dose cytarabine, wasn't getting a lot of patients into remission, pushing the envelope with some therapies 30%, 35%, but the vast majority weren't getting into remission. Those who did get into remission, we wanted to say, well, you've got to go on to a transplant because the long-term survival was otherwise poor. And you can see here that in the red curve, AML patients were getting more and more transplants over the last decade as transplant got safer and we got better at it. But the question is, is this what we want to do? Do we want to be getting more and more patients to allotransplant, or are there other things that we could do in the post-remission setting? Because still, allotransplant in patients over 60 is no fun. Can it be done? Yes. Does it have a high non-relapse mortality? It does. And the patients who are going into transplant with increased risk features, and older patients often have those, the higher your risk is going in, not surprisingly, the higher risk is for non-relapse mortality. So can we do it? Yes. Do we do it more than we did 10 years ago? Yes. Would we love not to be transplanting patients in their 70s and beyond? Yes. And I say that at great peril because I know there are transplanters hovering near me. So what else do we know? Well, we know here from Chris Hurrigan's work that actually there is a significant effect of the conditioning intensity on what happens with clinical outcomes, in that if you go into a transplant MRD positive, in this case as measured by deep sequencing, if you're getting a reduced intensity transplant, the outcomes don't look very good. If you're getting a myeloablative transplant, that looks better. But again, for many much older patients, ones I was mentioning in their 70s and beyond, historically, we have been trying to shuttle them onto reduced intensity transplants. And we can see here that although many of the patients in the past hadn't even been assessed for the presence of mutations before transplant, we're not as excited about taking older patients to transplant for reduced intensity procedures when they have residual disease, because the outcomes don't look great. So what else can we do? Well, after long effort, and I looked a lot better, I think, in the initial slide sets of QUAZAR, which were from 10 and 12 years ago. But finally, there was just recently the presentation and soon to be publication of the QUAZAR maintenance trial, which was an international phase 3 double-blind placebo trial of CC486, which is an oral formulation of azacitidine in patients in AML in first remission. And this is the exact group that we're talking about in this lecture today. So these are patients who are in remission, but what do you want to do after remission? Well, in this group of older than 55 patients, they weren't eligible to go on to transplant. There are a variety of reasons why they were ineligible, but again, you're in remission, you're over 55, you can't get a transplant. What happens? Well, you could get some consolidation chemotherapy. You didn't have to, but you could. And then after either consolidation therapy or not, you were randomized to the treatment phase of the study, which was CC486 or oral azacitidine versus placebo. This was a tough study, but we have long follow-up and lots of sampling for MRD. That's sort of a teaser for some data that may possibly be coming out in future meetings this year. But also the sampling looking at lots of different things, how the patients were doing, whether or not they had good quality of life. There was lots of follow-up. And as you can see in my follow-up box over there, and basically the money shot is over here that finally there is an overall survival benefit demonstrated for a maintenance therapy in AML. So there is a delta of 9.9 months and the CC486 arm 1. So this is the first time that a specific agent has conferred a benefit in overall survival in AML. And if you look over here in the key subgroups, age, sex, whether or not they got consolidation, whatever the MRD status was, there was a benefit for treatment with CC486, which all of a sudden begs the question that, okay, if you go back to the previous survival curves for a minute and you can see how long people are out. So there are people who are 24 months out, 30 months out, 36 months out. I have a patient who is many years still on the study. Well, that begs the question, at least, and this study did not randomize versus transplant, but if you have older patients who may not be able to go on to a transplant, and who may be surviving well and without evidence of disease years out from their initial diagnosis, it certainly begs the question of how are we going to make the decision of using something like this for post-remission therapy versus transplant versus anything else. It's nice to be able to have that discussion and something to think about. And in particular, we were gratified to see that the patients who had ongoing treatment with CC486 actually had preserved overall quality of life. So the last thing you want to do is have somebody in remission, and you can see by the time zero mark here on the slide that patients in remission with AML actually have quality of life that is pretty much like the rest of the world that didn't have AML. So it's a good quality of life, and being on therapy with this drug didn't mess that up. So I definitely think that this is going to be a new standard of care, of course, in the population tested, not eligible for stem cell transplant, but bringing up a lot of questions about who else can get non-transplant post-remission therapy. Now, what other post-remission therapies do we have? So if you look, for example, at the RATIFY trial, which was a randomized trial of chemotherapy plus or minus the addition of the FLT3 inhibitor midostaurin, for patients who have FLT3 mutated AML. The original study was for patients less than 60, but there were follow-up data from a German study group trial looking at patients older than 60. And here the idea was to give midostaurin, these patients could go on to transplant, but giving midostaurin maintenance either after consolidation without a transplant or in some patients after transplant. And I have to say that the data are still not fully study out specifically for midostaurin in terms of when to use it. We know that it confers a survival benefit when added to 7 and 3. It's a little bit more difficult to say specifically that gives a survival benefit if you give it without a stem cell transplant as post-consolidation maintenance or after stem cell transplant maintenance. But it allows me to open up the question of, for molecularly defined diseases like FLT3 mutated AML, what about using post-remission therapy with a FLT3 inhibitor? And there's a lot of work going into trying to analyze this question, not only for midostaurin, but also for next generation FLT3 inhibitors, like, for example, gilteritinib. The data are still out, but this was actually recently published in JCO, that there was relapse-free survival and overall survival in FLT3 mutated disease after stem cell transplant with sorafenib versus placebo. And here, sorafenib is not the new kid on the block at all, and it is considered the quote-unquote dirtiest of the FLT3 inhibitors in that it does a lot of other things, and some of its immunomodulatory effects may be particularly interesting in the post-transplant setting. But again, it brings up the question of, what do you do after somebody's in remission? And it is so, it's hard for patients and it's hard for doctors to not think of AML as just cured at some point, but to continue even potentially after transplant with ongoing therapy. It's good if it's helping with overall survival and it's tolerable. It's a little difficult to think about for patients who are hoping to be one and done with the treatment. Nonetheless, over here, I think it's continuing to argue that post-remission therapy for FLT3 mutated patients is probably a good idea, whether with sorafenib or another FLT3 inhibitor remains to be sorted out. Now, what about all of the patients who aren't getting intensive chemotherapy? So I was talking about QUAZAR, I was talking about post-intensive chemotherapy FLT3 maintenance, but that's not what we're doing for a lot of patients with AML, because those patients are older. The median age is in their late 60s, 67 to 70. And those are the ones who have historically been given single agent hypomethylators or low dose cytarabine, but now we have a change in the treatment paradigm. These slides, the next few were given to me by Courtney DiNardo, who presented this at EHA earlier this year. And this was a randomized trial looking at venetoclax with azacitidine versus azacitidine alone in treatment-naive patients. And this study is now the new standard of care for older patients. So these guys were older than 75, or they were 18 to 74 with a whole bunch of significant comorbidities. The trial was randomized, so standard dose azacitidine combined with placebo versus the combination with venetoclax. And this trial, actually, you can see here the breakdown of patients going on to the trial. So they were mostly intermediate, but some poor risk patients, a variety of somatic mutations. And you can see here the, again, what I'm calling the money shot is that this is an overall survival benefit for the combination of azacitidine and venetoclax. So now all of a sudden, you not only have a new regimen for older patients, but you have a lot of these older patients actually getting into remission. The regimen favored pretty much every subgroup that was investigated, including by cytogenetics and including by molecular marker. And if you look at the next slide, so this is a very complicated paper that would require much more discussion, but I highlighted here just to show that there are molecular patterns of response that are not only predicting relapse with venetoclax combinations, which is a subject for a different day, but that patients are becoming MRD negative and sometimes molecularly negative on this regimen. So it used to be thought that older patients on quote unquote non-intensive therapies shouldn't even be looked at for MRD negativity because the therapy wasn't quote unquote strong enough to get them molecularly negative. Now we know that that isn't the case, and actually MRD might be important in some of these older patients as well. Lots more work needs to be done there. So what are some potential agents for consideration in the post-remission setting, and what are some unanswered questions? Well, hypomethylating agents, and now we have actually 2 oral hypomethylating agents available. So clearly in the post-remission setting, having something that's well tolerated and easier to take at home would be attractive. We have venetoclax, there are FLT3 inhibitors, there are IDH inhibitors, there are a bunch of novel agents in development, including some immunotherapies, which may be able potentially to eradicate MRD. So what does one do with all of this? In the United States, we have the great news or terrible news, I think it's still great, of having lots of different things available, but you can't just randomly start doing things in the post-remission setting, because where remission after induction, remission after consolidation, how many cycles, remission after transplant, that all needs to be worked out. Of what I've listed here, what do you do alone versus in combination? So we need to have data, for example, on CC486 combined with some of these other drugs. There are clinical trials forthcoming on that. Do you need a combination of agents in the post-remission setting, or is one enough? Also, for how long? Is forever the right answer? Are we using a dynamic marker of MRD? And if so, what are we looking for? Does it have to be absolutely negative? Which modality? PCR, sequencing, flow cytometry? My point is not to try to answer all of these questions, because this talk is going to be over in a moment, but to just say that we need clinical trials, and we have all this fantastic stuff available now in AML. There's a lot more opportunity for treatment. There are more patients, including older patients, getting treated. We have a lot of potential excitement in the post-remission setting, but we don't really know the answers of what to do with all of these agents outside of the clinical trial settings where we have data. So please put your patients onto clinical trials. And thank you very much for your attention during this talk. I'd like to just highlight my colleagues at the leukemia program at Weill Cornell and New York Presbyterian. Thank you very much again.